This recording will go over assessment or noticing, labs, imaging, and other diagnostic assessments for cirrhosis. When obtaining a history, it's important to include the patient's age, gender, employment history, especially a history of exposure to alcohol, drugs, and chemical toxins. Keep in mind that all exposures are important, regardless of how long ago they occurred. Determine if the patient has ever had a needle stick injury. Sexual history and orientation should be asked because men having sex with men are at a higher risk for Hep A, B, and C. Inquire about whether there is a family history of alcoholism and/or liver disease. Ask the patient to describe his or her alcohol intake, including the amount consumed during a given period. Is there a history of illicit drug use, including oral, IV, or transnasal forms? Has the patient obtained a tattoo? If so, you want to ask them when and where they got the tattoo. For many people, the behaviors causing liver disease occurred years before the onset of their current illness, and they are regretful and often embarrassed. Ask the patient about previous medical conditions, such as an episode of jaundice or acute viral hepatitis, biliary tract disorders such as cholecystitis, viral infections, surgery, blood transfusions, autoimmune disorders, obesity or altered lipid profiles, heart failure, respiratory disorders, or liver injury. Because cirrhosis has a slow onset, many of the early signs and symptoms are vague and nonspecific. In terms of early signs and symptoms, you want to assess for fatigue, significant change in weight, GI symptoms such as anorexia and vomiting, and comfort alterations in the abdominal area and liver tenderness, both of which may be ignored by the patient. The patient with compensated cirrhosis may be completely unaware that there is a liver problem. The first sign may be present before the onset of symptoms when routine lab tests, pre-surgery evaluations, or life and health insurance assessments show abnormalities. You want to check for abnormal liver function tests. And also, abnormal liver function causes thrombocytopenia, so you want to also check on the patient's platelets. The development of late signs of advanced cirrhosis, called end-stage liver failure, usually causes the patient to seek medical treatment. GI bleeding, jaundice, ascites, and spontaneous bruising indicate poor liver function and complications of cirrhosis. Thoroughly assess the patient with liver dysfunction or failure because it affects every body system. The clinical picture and course vary from patient to patient depending on the severity of disease. Assess for obvious yellowing of the skin, known as jaundice, or of the sclera, known as icterus. Assess the patient for dry skin or any rashes. Assess for petechia and ecchymosis. Remember, the liver plays an important role in clotting since it normally produces vitamin K, which leads to the production of clotting factors. Without that, with liver damage, it can lead to bleeding for the patient. Also, in addition to that, thrombocytopenia or low platelets can also cause this. Palmar erythema, or warm and bright red palms of the hands, should be assessed for. Assess for vascular lesions with a red center and radiating branches, known as spider angiomas. Ascites, which is a collection of fluid in the abdomen, will lead to increased abdominal girth. Assess for peripheral dependent edema of the extremities and sacrum. Monitor for vitamin deficiencies, especially fat-soluble vitamins A, D, E, and K. Massive ascites can be detected as a distended abdomen with bulging flanks. The umbilicus may protrude, and dilated abdominal veins, known as caput medusae, may radiate from the umbilicus. Ascites can cause physical problems, for example, orthopnea and dyspnea from increased abdominal distension can interfere with lung expansion. The patient may have problems maintaining an erect body posture, and problems with balance may affect walking. Inspect and palpate for the presence of inguinal or umbilical hernias, which are likely to develop because of increased intra-abdominal pressure. Minimal ascites is often more difficult to detect, especially in obese patients. When performing an assessment of the abdomen, keep in mind that hepatomegaly or liver enlargement occurs in many cases of early cirrhosis. Splenomegaly is common in non-alcoholic cases of cirrhosis. As the liver deteriorates, it may become hard and small. Measure the patient's abdominal girth to evaluate the progression of ascites. To measure abdominal girth, the patient lies flat while the nurse or other examiner pulls a tape measure around the largest diameter, usually over the umbilicus, of the abdomen. The girth is measured at the end of exhalation. Mark the abdominal skin and flanks to ensure the same tape measure placement on subsequent readings. However, taking daily weights is the most reliable indicator of fluid retention. Remember, 1 liter of fluid is equivalent to 1 kilogram or 2.2 pounds. Observe vomitus and stool for blood. This may be indicated by frank blood or by a positive fecal occult blood test. Note the presence of Fetor hepaticus, which is the distinctive breath odor of chronic liver disease and hepatic encephalopathy, and is characterized by a fruity or musty odor. Amenorrhea may occur in women, with men experiencing testicular atrophy, gynecomastia, and impotence. Also look for bruising and petechia. Continually assess the patient's neurologic function. It may be helpful to include family members in conversations about the patient's baseline mental status if the patient is unable to effectively communicate. Subtle changes in mental status and personality often progress to coma, a late complication of encephalopathy. Monitor for asterixis, a coarse tremor characterized by rapid, non-rhythmic extensions and flexions of the wrists and fingers. It looks like hand flapping. The patient with hepatic cirrhosis may undergo subtle or obvious personality, cognitive, and behavior changes, such as agitation. He or she may experience sleep pattern disturbances or exhibit signs of emotional lability, which is fluctuations in emotions, euphoria, or depression. Repeated hospitalizations are common for patients with cirrhosis. It is a life-altering chronic disease, impacting not only the patient but also immediate and extended family members and significant others. There are significant emotional, physical, and financial changes. Part of the psychosocial assessment is determining if the patient is alcohol dependent. If this is the case, observe and prepare for alcohol withdrawal. Lab abnormalities are common in patients with liver disease. Serum levels of AST, ALT, and LDH typically are elevated because these enzymes are released into the blood during hepatic inflammation. However, as the liver deteriorates, the hepatocytes may be unable to create an inflammatory response, and the AST and ALT may be normal. ALT levels are more specific to the liver, where AST can be found in muscle, kidney, brain, and heart also. An AST-ALT ratio greater than 1.0 is usually found in alcoholic liver disease. For our purposes, even though it says as the disease progresses, AST and ALT may become normal again, when we're thinking about cirrhosis and the abnormal lab values we're going to be looking for, we would include elevated ALT and AST. So that's what I want you to remember. Increased alkaline phosphatase and GGT levels are caused by biliary obstruction and therefore may increase in patients with cirrhosis. Alkaline phosphatase is a nonspecific bone, intestinal, and liver enzyme. However, alkaline phosphatase also increases when bone disease such as osteoporosis is present. Total serum bilirubin levels also rise. Indirect bilirubin levels increase in patients with cirrhosis because of the inability of the failing liver to excrete bilirubin. Therefore, bilirubin is present in the urine in increased amount. Fecal urobilinogen concentration is decreased in patients with biliary tract obstruction. These patients have light or clay-colored stools. Total serum albumin levels are decreased in patients with severe or chronic liver disease as a result of decreased synthesis by the liver. Loss of osmotic pole proteins such as albumin promotes the movement of intravascular fluid into the interstitial tissues. PT and INR is prolonged because the liver decreases the production of prothrombin. The platelet count is low, resulting in a characteristic thrombocytopenia of cirrhosis. Anemia may be reflected by decreased red blood cells, hemoglobin, and hematocrit values. The white blood cell count may also be decreased. Ammonia levels are usually elevated in patients with advanced liver disease. Serum creatinine may be elevated in patients with deteriorating kidney function. Dilution hyponatremia may occur in patients with ascites. Plain x-rays of the abdomen may show hepatomegaly, splenomegaly, or massive ascites. A CT scan may be requested. MRI may also be used. It can reveal mass lesions, giving additional specific information. This information is helpful in determining whether a condition is malignant or benign. MR elastography is a type of MRI that provides a way to assess liver elasticity, which helps the healthcare provider determine the amount of liver disease present. Ultrasound of the liver is often the first assessment for an adult with suspected liver disease to detect ascites, hepatomegaly, and splenomegaly. It can also determine the presence of biliary stones or biliary duct obstruction. Liver ultrasound with Doppler is useful in detecting portal vein thrombosis and evaluating whether the direction of portal blood flow is normal. Some patients being assessed for liver disease require biopsies. The healthcare provider may request an arteriography if ultrasound is not conclusive in finding portal vein thrombosis. The healthcare provider may also perform an EGD to visualize the esophagus, stomach, and duodenum for complications associated with cirrhosis. An ERCP uses the endoscope to inject contrast materia via the sphincter of Oddi to view the biliary tract and allow for stone removals, sphincterotomies, biopsies, and stent placement if required.